Hello and welcome to the VEITHsymposium 2019. I'm Steve Elias. I'm the director of the Center for Vein Disease at Englewood Hospital and Medical Center in New Jersey. And I'm speaking with Tom O'Donnell, who is from
Tufts
Medical Center, who is also a very good friend of mine and one of my mentors. But one thing that Tom did not teach me about way back was about lymphedema, because lymphedema back in the day was something that nobody wanted to talk about. But we're going to talk about lymphedema today. So Tom,
Parenthetically, not to interrupt you, but I will tell you that lymphedema was the only vascular disease that one vascular surgeon would refer to another.
Exactly. So I guess my question to you is, why now? Why in 2019 we have articles, we have discussions about lymphedema? What made it rise up? We even have societies that are changing their name, the American Vein and Lymphatic Society, to include that.
Well, I think you mentioned one of the moving forces was the societies developing an interest in promoting education, and a number of the industry partners have done that to educate people on lymphedema and potential treatment.
But do you think it's at least when, training and growing up in the vascular world, it seemed like, well, we can't do anything about it, so I don't even want to talk about it kind of thing. What techniques, technologies, what changed, not in 1 year, but we've been doing it for a couple of years, what changed that now makes us feel good, so to speak, about treating lymphedema?
Well, I think it's the growing ability to put a patient through a protocol of reducing limb size, starting with physical therapists who help perform the specific massage, which is different than a deep tissue massage. It's a massage oriented to promoting lymphatic flow, so it's very superficial. That's phase one, and then phase two, we have better pneumatic compression devices that the patient can use at home to continue the reduction or sometimes even improving on. And finally, I think people are becoming aware of potential surgical approaches, although that amounts to about 10% of most lymphedema patients. But when a patient gets to an advanced stage 3 or 3 plus lymphedema, reduction of the limb size is very important, and then going back and using continued intermittent pneumatic compression. So I think those 3 steps are what's allowed it to become, people to become more aware that they can treat it.
Right. Now let's talk about, some people say, oh, I can look at a leg and I know it's lymphedema. And do you think in general that's true the majority of times? And tell me when there are times that someone may need to do something else to either rule in or rule out the diagnosis.
Well, first of all, the majority of patients that vascular surgeons and others see are secondary lymphedema, not primary, which is very unusual. And in those cases, the primary, there's a typical history, particularly young women at the age of menarche, they develop swelling in their left leg. And then on the physical examination, there's very characteristic distribution of the edema. In the secondary lymphedema patient, the commonest cause is breast cancer. So it doesn't take a genius to figure out.
Yeah. Cause and effect. Right.
Yes. Lower extremity lymphedema is different. The most common cause there is a venous etiology, usually venous ulcer, phlebolymphodema. So that helps make the diagnosis. I think it's important in questionable secondary cases to consider doing lymphoscintigraphy or a CT scan, because you may find a patient who has developed a recurrence of cancer, which is causing blockage of the lymphatic drainage. So those patients with previous abdominal, uterine, pelvic cancer, I think a CT scan is in order.
All right, now let me ask you, in the workup, if it's not a history of something like cancer or whatever, do you think it's important in unilateral lymphatic leg swelling that you do need to rule out some pelvic issue that may be causing it?
Yeah, I usually start, as I know you would, with a duplex ultrasound, which can look at the veins and see if they themselves are a cause. It also can look in the inguinal area and see if there are any enlarged lymph nodes. But I generally have no hesitation in getting a CT scan for a patient who is not straightforward, because it may reveal something that you didn't think.
Yeah, no, and I think that's important. A lot of times people don't talk about it. They say, oh, it looks like lymphedema. I'm going to treat it like lymphedema, and the patient has some underlying other cause as well. The other hot topic that, and you alluded to it already, is the concept of phlebolymphodema. Venous combined with lymphatic disease, the chicken or the egg kind of thing. Give us a little bit insight into what's the thinking nowadays regarding phlebolymphodema in terms of etiology, and then we'll get into treatment.
Well, first of all, it is probably the most common cause of secondary lymphedema, even more than breast cancer. The problem is many cases go undiagnosed and untreated. So that's the first concept. The second is that patients with phlebolymphodema, even early venous disease, have problems with their lymphatics. And many people approach the disease, venous disease, that the patient is leaking due to venous hypertension, fluid into the interstitial space, and it's going to be reabsorbed on the venous side of the capillary. That's incorrect. That's been disproven. So when a patient has phlebolymphodema, the only way to get the interstitial fluid out of there is by the lymphatics. In early phase phlebolymphodema, there is tremendously increased flow, and sometimes that exceeds the ability of the lymphatics to clear it.
Yeah, like an overflow.
Later on, particularly due to secondary infections, the lymphatics themselves can be damaged and it becomes obstructed, and that compounds it.
All right, so what's our treatment algorithm for phlebolymphodema? How aggressive are we in treating the venous side of it, for instance?
Well, I think in treating the venous side, the first thing you should do is see if there's a treatable cause.
Yeah.
As you've done in your practice, i.e., can you reduce venous hypertension by treating the saphenous? Is there outflow obstruction? Beyond that, if there's remaining deep venous valvular incompetence, you've got to treat both the veins in the lymphatics. From our studies of 27,000 patients in a large database, a smaller percentage of patients with phlebolymphodema undergo treatment than breast cancer patients.
Wow.
So there's a treatment gap. 82% of phlebolymphodema patients, if they're recognized, get some form of treatment. By contrast, 96% of breast cancer.
Right. So I think, the takeaway from this, I mean, we're going to just kind of wrap it up here, is that there are good modalities, to make the diagnosis if necessary, but more importantly nowadays, to treat the lymphatic side of the problem and the venous side of the problem. Finally, just one thing. What is one thing that's missing that if you could do it for the management of phlebolymphodema or lymphedema that you would say?
Well, I hate to say this. I'd like to be able to correct the venous hypertension when you've exhausted your surgical approaches, and therefore some way of treating deep venous incompetence will be very important in these patients.
Okay, Tom, thank you. As always, very informative.
Good seeing you, Steve.
Yes. All right.
Bye-bye.
Take care.